So I'll get straight into it, and you'll see my first two slides are very corporate, that they're very similar to Jackie's. It is an opportunity to bridge the gap today between fitness professionals and medical professionals, and we do need to do this for the reasons that Jackie espoused and I endorse, obviously because we have very similar slides for our first two slides. And we know all these pieces of information that incontinence is embarrassing. If it keeps going, it leads to acceptance by the woman. There's a lot of misinformation about it's normal for ageing, treatment doesn't really work. TV advertising is all about pads, not about doing anything about it. It does affect women more than men, and women are more likely to withdraw from physical activity anyway, and if they're affected by continence, there's a double whammy. So we need today to think about the relevance of this for physical activity. This is our pelvic floor fitness program that we're talking about today. It is very, very unfortunate if women do withdraw from physical activity because of the lifestyle diseases that occur if we do withdraw. If women do continue to exercise while they do have incontinence, sometimes the physical activity they do can make it worse, which is why we need the pelvic floor safe exercises. And that's a segue into Marietta's talk, which I will leave there for Marietta to take up the baton. So I've talked about two things. We've talked about the pelvic floor and we've talked about incontinence. So we've got to know then, well, where does incontinence fit into this? We've got to do some definitions. So what is pelvic floor dysfunction? There are lots of pelvic floor dysfunctions, and incontinence is one of the first on the list. And there are many subtypes of incontinence. Stress incontinence, that's physical stress, not mental stress, and urge incontinence, and you can have a mixture of those two. And they're all problems of storage, that it's difficult to keep urine in the bladder. There's also problems with voiding as well, and some people can have difficulty getting urine out. The image there is obviously a storage problem, but it shows that even the most elite athletes can have incontinence in a very public place. There's also problems with bowels, and as the CFA promotes bladder and bowel health, we must remember fecal incontinence as well. And we have the similar problems of storage and of defecating. Then there's also all the prolapses. Gravity is very endemic, and as we age, gravity tends to pull things down, and prolapse means a falling down, and any of the pelvic organs can fall down into the pelvis. And they're measured by looking at what's happening within the vagina. Pelvic pain is also a pelvic floor dysfunction. It can be from spasm of the pelvic floor. It can be of the skin conditions around there, and it can then lead to sexual problems. And it can even be represented as back pain. So a lot of people have back pain, but they don't associate with their concurrent leakage as well, or their concurrent pelvic pain. So pelvic floor dysfunction covers a whole wide variation of terms. But today we're focusing more on the pelvic floor and continence. So let's look at the pelvic floor. There's always a bit of anatomy we have to learn. This is part of the human body. And this is a lovely image, pen and ink drawing of the underneath side of the pelvic floor. On this diagram, you can see that there's a couple of layers of the pelvic floor. A layer that is superficial, that surrounds the front organ, the vagina and the urethra. Superficial muscles that are more muscles of sexual dysfunction. And then the deep sheath of muscle that's underneath is the true pelvic floor muscles. Once again, not a single sheet, but made up of 3 different muscles. So the pelvic floor is really a diaphragm. It's a sheet, like a diaphragm of muscle that is supporting the internal organs, but more complex than a simple diaphragm. Looking from above, you can see that it is a bit like a shallow bowl. So we've cut the pelvis in half in this image, and you can see the midline organs, at the urethra, the vagina, and at the back, the anus and rectum, and how the organs, you can imagine then, how they would sit on the pelvic floor, and how the pelvic floor muscle itself acts as a trampoline, an elastic support to really support these organs when you move, jump, cough, sneeze, etc. So here's the image with the organs on top of the pelvic floor. So it's a cutaway image again, and you can see the cut edge of the pelvic floor underneath the organs, the bladder to the right-hand side of the image, the front of the pelvis, the uterus, the vagina, and the rectum at the back. And here is the pelvic floor muscle underneath. So the pelvic floor is this lovely diaphragm sheath, and then underneath we've got the muscles that surround the outlet pipes around the anus at the back and around the vagina and urethra at the front, and help support the clitoris. And so some of these muscles are also, as I said earlier, they're muscles of sexual function. Technology has improved dramatically, and so I've put a slide in here to show that we can see a lot about the pelvic floor using ultrasound. The top left-hand diagram shows how you could peer into the pelvis from the lower abdomen. So we have a patient lying on their back with an ultrasound transducer peering down into the pelvis. Here's our pen and ink diagram, again, with the pubic bone at the front, the bladder, the uterus, vagina and bowel at the back, and the pelvic floor muscles coming along the floor. If we put a probe there, we can see the lift of the pelvic floor. And on the two bottom diagrams, you see then the ultrasound images themselves, a full bladder, the uterus. We can't see the bowel very clearly. And on the right-hand side, you can see when the pelvic floor lifts, you get a rise. So we can assess a pelvic floor knowing our anatomy and having wonderful imaging technology these days. I want to talk a little bit about the function of the pelvic floor. I've said already that it supports the organs. The diagram that's here on the right of the image is a very useful one to use for your clients or patients. It's not mine. It was first devised by a fairly famous American gynecologist called John Delancey. But it gives a really good idea of how the pelvic floor, which is represented by the water here, supports a boat, which represents our internal organs, to the bony pelvis, the docks on either side. Along with the muscle, though, we also have ropes to hold the boat against the harbour, otherwise it would knock sideways. So we have a lovely stable situation here with inelastic ligaments, a floor that goes up and down with the tides, and a weight that it supports, a boat. Okay, so we haven't got a decent pelvic floor anymore. What happens? The boat is still fairly stable because it has ligaments or ropes, but after a time they're going to fray, they're going to stretch, they're going to have to do more work than they were designed to do, and so we get a falling down of the organs and leakage from them. So it's a really good diagram to use with clients and patients to explain why we need a good pelvic floor. So this is our first function: support the pelvic organs and resist any downward force from raised intra-abdominal pressure. You can imagine that boat, if it were a heavier boat, or if a great force of wind pushed it down lower, how much more force there would be on the floor. And that's what happens in exercise, of course. Not shown in that diagram is we need good muscle strength to close around the openings, to act like sphincters for the urethra and the anus. So our pelvic floor needs to be responsive to changes of movement, of posture, and it needs to act fast and strong, and it also then needs to relax. We don't want our pelvic floor muscles to be on hold all the time. Otherwise, you're going to get very fatigued. You're sitting there in your chairs all around Australia. If your pelvic floor was firing all the time, it would be even tiring to sit down. So we know then that we have a floor that supports everything. But is there too much? What are risk factors for too much load versus the integrity of the muscle? So let's look at how we load the muscle. We can put too many fat cells above it. We can jump around too much and put too much gravitational force. By coughing, we put more pressure on the pelvic floor. So people with chronic lung disease have trouble with the load that's always being forced down onto the pelvic floor. A more subtle form of straining is with constipation. That daily, year after year, straining with bowel motions can be just as damaging to the pelvic floor as star jumps. And of course, heavy lifting. Saying, I can lift anything. I can put the caravan on the tow bar. I can lift a full load of wet washing to take out to the line instead of 2 half loads. All that strain presses down on the pelvic floor. When we look at the structure of the pelvic floor and what could reduce the integrity of that structure, we have a long list. The top 3 we can do something about, can't we? We can improve muscle. Any muscle in our body can be improved. I'm going to show you in the next couple of slides that posture makes a difference. Yes, your grandmas were right. You need to sit up straight, you need to stand up straight. Good posture is a key to making the pelvic floor muscle work efficiently. And physical activity, toning up your whole body, improves the integrity of the pelvic floor as well as your butt, your tummy, your shoulders or whatever. Right, now let's look at the next 3. Pelvic surgery is going to have some sort of effect on the pelvic floor. Obviously, if you go for surgery, you need to improve the organ support above the pelvic floor muscle itself. But I wanted to show you something about the surgery. Here is some very interesting research that was done in the United States a few years ago, reported in 2005. On the y-axis, the vertical axis, is the percentage of recurrence and reoperation rates, versus on the x-axis is the strength of the pelvic floor, from a 0 strength, like no muscle action at all, to the strongest muscle action. Just visually, you can see how much more recurrence and reoperation rates are with women who have very weak pelvic floor muscles versus those who have strong pelvic floor muscles. So even going for surgery, which may be necessary, you can still have a better outcome from your surgery if you have strong pelvic floor muscles going into the surgery. And this research group showed that pelvic floor muscle strength correlated really strongly with additional surgery and recurrent incontinence. In other words, the stronger muscles you have, the less incontinence you have. But they found that prolapse was different for those people who are interested in the hiatus of the pelvic floor. You can see then prolapse most correlated most strongly with that. So we then look at pelvic neuropathy. Whenever you stretch nerves or compress nerves, they don't regrow as well as they were in the first place. Well, how can you stretch or damage pelvic nerves that are inside your pelvis? Well, you can with childbirth, and you actually do with surgery as well, because no matter what you cut, stitch, sew, you're going to damage the fine mesh network of nerves that are inside the pelvis. So there's always some neurological damage when something happens inside the pelvis. So this leads on to the next one. It's been shown that after 4 children, there is more damage to the pelvic floor. So limiting the size of the family, while it's a very sensitive topic, is a very good thing for maintaining the integrity of your pelvic floor. Now, the last 2, gender and increasing age. Being female and getting older is not a good thing. We can't do anything about that in terms of growing older and being female. However, think of all the risk factors I've just talked about, and you can do something about making your ageing healthier if you are a female. I thought I'd put in a very quick slide about risk factors for men, and you can see how short it is. That's it. Getting older and prostate enlarging, or if you actually have trauma to the pelvis itself. So you can see why, as Jackie said, so many of the incontinent Australians are females. All right, so we have a situation. We know what the pelvic floor is like. We know that incontinence is one of the pelvic floor dysfunctions. If you treat it, is it any good? No, is it worth treating it? Yes, it is. This is a cost-utility diagram, or cost-benefit, that most of us use the term cost-benefit. You can see to the right, the third right column here is urinary incontinence, showing that you get a huge amount of utility or benefit from treating urinary incontinence. So while it's endemic, it should be treated because the costs of treatment cause so much more benefit to society. And even fecal incontinence, which is harder to treat and more disabling, is still has a high benefit for treatment. So yes, these studies have shown that it is beneficial to treat incontinence, getting onto it and getting treated. All right, what's the main treatment that we have fabulous evidence for? Yes, it's pelvic floor muscle training. And the Fourth International Consultation on Incontinence gives it a level 1A of evidence and grade A recommendation, which in the Oxford grading system is a level of recommendation that should be on all national guidelines. So here we go, really high evidence that pelvic floor muscle training should be offered as first-line therapy to all women with stress, urge and mixed urinary incontinence. Now, I'm talking as a physiotherapist. I'm biased, I'm a physio. Pelvic floor muscle training is the mainstay of physio treatment, but it's not all we do. However, training is more than just doing that squeeze exercise. We can train muscles in all different ways. We can train for motor control. Now, what does this mean? Do you know people, it might be yourself, I don't know, who wherever they tighten their pelvic floor go like this? And they can't separate their breath from their pelvic floor. That's not very useful, is it? Because when do most people leak? When they cough or sneeze, which is a forced exhalation. It's not a breath holding. So as soon as you cough or sneeze and you can only hold your breath and tighten your pelvic floor, you're going to leak because the pelvic floor will relax. So training for motor control to separate out breath and pelvic floor contraction, like I'm tightening my pelvic floor now while I'm talking to you, to show that it is possible actually to talk, chat, move around and hold your pelvic floor tight. So motor control is really important. Coordination with arms, legs, lifting weights, walking is really important. Getting basic strength, yes, in any form of training you have to get strength, but you also have to get power, which is how much strength per unit time. Being able to repeat a strong action again and again and again. And if you're a runner or a person who loves walking, your pelvic floor needs to be able to hold the full hour of your exercise. So you need power as well as strength. Also need endurance to stand in the queues, sit through the last bit of the movie. You don't want to be leaving just as the movie's getting towards the exciting end. Being able to hang on for a long time. And you should be able to use it in functional situations. Tighten your pelvic floor before you lift. Tighten your pelvic floor before you cough. So teaching people to use the strength that they have. So you can see training isn't just that squeeze exercise you do at the red lights. There's a lot more to it than that. We also need to know about the fact that the pelvic floor doesn't work on its own. It's not a little muscle that sits there working independently. It actually works with the rest of the trunk. So you can see in this diagram that you've got a pelvic floor at the bottom of the diagram. You've got abdominal muscles that go all around the trunk, the cylinder, and you've got a respiratory diaphragm at the top. Now, we know that this trunk of ours is a pressurised capsule, like a balloon, and the pelvic floor forms the base of it. And if we are thinking about the relationship between the pelvic floor and the rest of our trunk, we need to know, is there a relationship between these muscles? And we find that there is. All of them have postural roles and all of them have dynamic roles. So my pelvic floor will hold me while I'm standing here, but it will also tighten and let go, etc. Now, if you need to use the dynamic role more, your postural role decreases. And we all know that because what happens when you sneeze? When it's a really dynamic, fast action of the respiratory diaphragm, which is going to increase a lot of pressure in the abdomen. Do you stand up straight and sneeze in perfect posture? No, what do you do? You lose all your postural control. So I want you to remember this when you're teaching people pelvic floor exercises, when you're thinking about safe pelvic floor exercises, that if we're asking too much demand in the dynamic sense, we're going to lose some postural control. And we know even more than that. We know that the pelvic floor actually works with the lowest part of our abdominal muscles, the deepest and lowest muscle, which is called transversus abdominis. We know, like your grandmother said, stand up straight, that your pelvic floor muscles are more effective in lumbar lordosis. That's normal lumbar position. Everybody around Australia who's watching and this room, I just want you to note how you're sitting. Okay, everybody's relaxed. In this room you are anyway. I want you all now to pull your backs away from the back of the chair and sit upright. I want you now to think about what's happened to your pelvic floor. Can you feel an extra tone in your pelvic floor as you're sitting up straight? To get the contrast, I want you to all go back into your relaxed sitting again. Think about your pelvic floor. Now, sit up forward and lengthen through the spine. Sit upright. Can you feel an extra tone in your pelvic floor? So just by sitting up, you are making your pelvic floor muscles work better. They work better in their postural role. Okay, you can go back into your comfortable posies again. Now, does this work all the time? No. Unfortunately, we've found in research that this synergy is commonly disrupted in people with pelvic floor dysfunction. So we can't assume that everybody is going to have this function. And in fact, in some research that I conducted at Melbourne Uni, we were looking at the pelvic floor when it was combined with a transversus abdominis contraction. And when we asked the people to do a transversus contraction alone, 30% of our subjects actually depressed the pelvic floor. And this was a great surprise to us because we thought we were going to get the best contraction when we combined the transversus abdominis and the pelvic floor. And then we looked at those women later, they all had pelvic floor dysfunction. So we can't assume that this synergy always works. So those who are interested in theory and background can listen up now, and those who just like the clinical work, this is your 30 seconds of rest time. I'm going to a bit of physics now. Okay, so choose which we want to do. Why does this pressurised, how does this pressurised capsule work? I'm going to put a picture of a balloon at the bottom here. This is your trunk lying down, and the little part at the end is the urethra on the left-hand end of it. So, in this sealed abdominal capsule, the pressure is equal throughout. It was Pascal's law, which you learnt somewhere in Year 8 physics or science. The wall tension that's required to keep the pressure inside this balloon varies, but it varies with the radius. So the T equals PR. Tension equals the pressure multiplied by the radius. You can already see why obesity is a problem, can't you, or pregnancy, because if this radius expands, we need so much more tension in the wall. What if we haven't got it? Down at the end of the balloon where it's rounder, i.e. our pelvic floor, the tension's only about half that's required in a cylinder. So we're really well designed. Our pelvic floor doesn't have to be as strong as our abdominal muscles. Isn't that wonderful? But, and down in our urethra, we don't have to have as much tension in our sphincter muscles either. Now, this is all very well and good if everything's fine, but what say we do a sit-up and we don't have strong pelvic floor muscles? We're going to put a lot of pressure there and a lot of pressure downwards on the pelvic floor. So sit-ups, if we haven't got a good synergistic action of the abdominals and the pelvic floor, could be a really bad exercise for the pelvic floor muscles. I want to talk about jumping too, because on my very last slide, I'll let you anticipate this already. One of the actions from today's seminar is I want star jumps for women banned. Okay, so here we have jumping on a trampoline. The girl in the left is jogging on the trampoline, the girl on the right is jumping. So why have I suggested that running on a mini tramp is better than jumping on a mini tramp? Let's look at the forces. In the left-hand diagram, you can see all the forces are going down the bones of the leg that's the stance leg, the running leg. And across the pelvic floor, there's far fewer forces because the force goes down through the bones. When we jump on two legs, we've got a nice sling diaphragm here, like a suspension bridge between the two legs, and we're getting equal force across the whole of the suspension bridge. Not good for the pelvic floor, especially if we don't have a strong pelvic floor. put the legs apart and repeatedly do this, oh, it hurts me to think of it. Okay, so we can already think about some at-risk people who do activities that raise the intra-abdominal pressure, and I'll leave you read the list, but it's high impact, it's heavy lifting. People who are deconditioned and still want to do exercise. If we add pregnancy, that adds another dimension altogether because we have hormone changes as well. So you can see why pre-screening, exercise screening is really, really important for the pelvic floor. And as such, in the physiotherapy world, we have red flags, yellow flags. Red flags are alert, warning, this person really needs your care, and blue flags, so we can be calmer about this. So I present you these red flags. If your client in the gym, your patient in front of you is already incontinent or has other symptoms of pelvic floor dysfunctions, they are, and these are the dysfunctions that you should be really careful of, they need treatment. Okay, this is an alert. And notice the last dot point is back problems, if they've got lower back or sacral neurosigns. What about blue flags? These are people who would be at risk of incontinence. They don't have it, but they're at risk of it, and these might be more the biomechanical or the medical/surgical factors. And we have a whole list of them, which you could probably almost guess by now. The elite trainer. Don't forget, people who are very fit may still have biomechanical problems that may lead you to think, this is not a danger signal, but an alert. Medical conditions, connective tissue disease. There is an association with the autoimmune connective tissue diseases, lung disease, neurological diseases, particularly spinal, and the bowel disorders. And we have to think of the medications that people are on as well. Okay, so I've told you all, that sounds really nasty, like, is anything worthwhile? That's a big problem. What do we do next? Offer advice at treatment? What's the evidence for our treatment? Who's best placed to deliver the most effective service? Well, we always have the 6 R's when we talk about clinical effectiveness, so I'm going to finish my talk by going through the 6 R's. First of all, the right person. There's strong evidence for good outcomes if patients are treated with incontinence are treated by pelvic floor physios, not just the corner physio who does ankles and has an ultrasound machine. It's people who can do some good clinical reasoning and go through the full pelvic floor dysfunction assessment. So outcomes that are in the literature can't be generalised to other health practitioners who don't have that specific training, and there's a Cochrane review on that in 2006. Now, fitness leaders are at the coalface, so it's the fitness leaders who get to do the screening, and I think you're in a really important position to screen patients, look at the red flags and the blue flags, and refer for a pelvic floor check. Now, the right thing. Self-help is not the best because we have quite a bit of evidence to show that more than 30% of women aren't able to contract their pelvic floor at the first session, even if they've had really good instruction. But if it's not, the pelvic floor is not visualised, it's not imaged, we don't know what's happening inside the body. Patients sitting there in front of you saying, yeah, I can feel a squeeze, I think. They might be feeling a bearing down, but their perception isn't right. They don't know whether they are lifting or bearing down. There was some interesting work done where a pressure transducer was placed inside the urethra to look at how much pressure the pelvic floor is providing around the urethra, because that's what we want. We want to close the urethra, don't we? We don't want any urine leaking out of it. And people doing their squeeze exercise at the red lights, only about half of them were actually doing it hard enough to close off the urethra. So if a woman comes to you and says, I've been doing pelvic floor exercises ever since I had my baby, they've been doing it at the same level all those years. They've never been training. They've never been increasing their strength. And it was found that 25% were actually straining, not tightening their pelvic floor, not lifting. If people help themselves and say, yes, I'm doing the squeeze exercise, but I'm not improving, that's really demotivating, isn't it? We all know it with our exercise clients. If they can't achieve it, they end up not coming to our classes. And so we've got a lost opportunity there, and they say, oh, just go for surgery. And I showed you a slide just before that reoperation rates are pretty high. So I think that we have a duty of care to talk about pelvic floor issues. As Jackie said, we need to raise awareness of pelvic floor as a part of our normal clinical practice or our normal exercise practice. And I know there's no male instructors in this room, I don't know anywhere around Australia listening to this talk, but that includes male exercise instructors who need to talk about pelvic floor issues, because most people who come to the gyms, in classes at least, are women. Now, the right way. We need to think further than just the pelvic floor. I've talked to you about how the pelvic floor interrelates with the trunk. So it's not just pelvic floor exercises, and this is where Marietta's going to take over talking about pelvic floor safe exercises. And don't think clients or your athletes have got it right without checking. Band star jumps. Absolutely. What about transabdominal ultrasound? Just about every sports physio clinic at the corner has got an ultrasound, and it's very easy to put a transducer on the abdomen and look at the pelvic floor. Oh yes, it's working. Well then why have I still got a problem? And that's the difference between seeing the muscle working and actually doing the clinical reasoning to find out what the cause is. So that's where you need to refer to someone who's qualified. So it's excellent biofeedback from muscle activation, but it doesn't give us the whole picture and doesn't qualify the ultrasound practitioner to actually treat pelvic floor problems. Now, what about the right place? What about your gyms? Is there anywhere private to discuss issues? You're not going to pull someone out in the middle of class and ask, why aren't you participating fully in my star jump class? So there has to be some private way, and as a fitness instructor, your openness to talk about these things is really, really important. Maybe there could be some general information placed in change rooms in the gyms, around the walls. We've got plenty of literature already produced by the CFA and by the Jean Howes Foundation, so it's not that it's not out there. And talking about the exercise instructors, at the beginning of the class you might just talk about the pelvis as a part of the body like you would the shoulders or the ankles or anything else. When's the right time? Now. I think we could almost call it out as a mantra. It's the World Continence Week, so this is the perfect time for us as professionals to be talking together and then go away from this week and this talk doing something about it, not just saying, oh yes, she talked a bit about it, yeah, but I don't know whether I'll do anything right now. Yes, now. Make sure that your words are timely for the patients. It might be timely for you, but it's got to be timely for your patients and for your clients. And if you do start talking, then you also need to know where services are, how your clients and patients can access them. We have a helpline, we have websites, so out of this session today we have plenty of availability for our clients. And if we do all that, we will get the right results. Optimal outcomes do occur if these principles are adhered to, as long as we give the right message. And here's my little funny for the day. To stay young, the doctor said to exercise and eat the right foods. What? I thought he said accessorise and buy nice shoes. So we do have to have our language right, and it has to be the same across our professions. So finally, let's understand each other's professional strengths and boundaries for best collaboration between us all, for quality service and for patient satisfaction. Let's communicate between us. What's the best way? For each of us it'll be different. You'll know your local physio, doctor, gynaecologist, pelvic floor professional. Get together, start talking. Remember that the pelvic floor problems are complex and they do require trained practitioners and who can respond properly with appropriate management. But all of us need to be aware of the signs and symptoms and be prepared to ask our patients and our clients. So thank you very, very much for listening, and hopefully you'll go out and do. That'll be the success of my talk today.